Good night, everyone. And thank you all for joining us for this very timely symposium that has been organized by the Ministry of Health, Public Hospital Authority, and the UWI, and it is on the aftermath of COVID-19. We have 3 sessions that are going to be done every Thursday, today being our first one, and we have some very interesting and lively topics with some dynamic speakers. And in addition to that, we will have another one next week, Thursday, and the last and final session will be on the 28th of January. So I think that you all would have seen the notices and the list of the speakers. So I'm inviting all of you to attend each session. We actually got awarded CME credits as well. So there'll be 2 CME credits available per session, and it requires that you complete the evaluations at the end of the session. So thank you very much for coming in and being a part of this important symposium. Each talk will be 25 minutes duration with 5 minutes for question. And we are going to be starting at 6:30 each night, and it will go for an hour and a half. Our very first speaker is Dr. Dion Dames, and she's very much a part of UWI and very familiar to all of us. She attended the University of the West Indies for medical school, and actually is one of the earlier graduates from our own DM internal medicine program. She's a clinical tutor for the DM internal medicine program currently, and she actually succeeded Dr. Sawyer, who was our first clinical tutor in that area. I'd like to congratulate her personally for her outstanding performance in the recent DM examinations, where there was 100% successful passing both at the DM2 and the DM1 level. So I think that is something that needs to be recognized, and she is very much an integral part of that success. She's a consultant in the internal medicine department and was a very active provider of care during the COVID-19 pandemic that has raged a war on us and the world since March 2020. And the biggest impact has been on adults. I looked up the most recent statistics, and there have been over 1,400 active cases with 175 deaths that have been COVID related, 37 non-COVID deaths in the group, and 15 under investigation. So the toll that this has taken on the adult population of physicians and nurses, my heart goes out to the work, to the entire Department of Medicine in particular, and the emergency room department, which took the brunt of the trauma that COVID-19 raged upon us. Dr. Dames is also the chairman for the medical staff at Doctors Hospital, so she would have been involved even at that level in the private arena with looking after COVID-19 cases. And she has been actively involved in the Medical Association as well, and has been a conference chairperson for several of its conferences. I'd like you to welcome Dr. Dion Dames as she gives us her talk on the tsunami that swept twice COVID-19 in the Bahamas. Dr. Dames, please take over.
Hi, good evening, everyone. Thank you for joining us, and Dr. Sinqui, thank you for your kind words. My name is Dr. Dion Dames Raming, and as Dr. Sinqui pointed out, I'm a consultant in internal medicine. Now, I've been asked to give basically an overview of COVID-19 in the Bahamas, and as you may appreciate, we've had 2 waves thus far. Let me see if my slide will advance. Okay. So the objectives of this talk is to discuss a little bit about the epidemiology of COVID-19 in the Bahamas. We're also going to look at some of the factors that contributed to the spread within the Bahamas. And there were policies that were implemented, and we'll discuss a little bit about how they impacted the spread. And we'll talk about the different factors that contributed to the second wave and what we can do in the future. So most of us were paying attention as they talked about on the news. Hold on one second for me. I do apologize. Let me see if I can get this. Now we do. Okay. So in December 2019, in Wuhan City, there were description of a significant respiratory illness that was more severe and more potent than the regular influenza virus. To be honest with you, there are many who think that the first emergence was actually in mid to late November when they were seeing some of these cases. And despite the fact that there has been a lot of conversations about how the virus came to be, at this point in time, it really doesn't matter. We know that the coronavirus existed and it caused severe respiratory illness. Now, the disease caused by the novel coronavirus, we know it as SARS-CoV-2, but it was named COVID-19 by the World Health Organization in February 11, 2020. This was the coronavirus disease 2019. And as we sat back and we looked, we noticed that globally there was significant spread. Not only was it spreading, but the rate at which we were seeing spread in this global pandemic was significant. So most of the healthcare providers in the Bahamas actually were paying attention to what we were seeing happening worldwide. And we knew that it was only a matter of time before COVID made its landfall in the Bahamas. The Ministry of Health and the public hospital authorities were talking on many different levels of preparation for the arrival of COVID-19. Despite the fact that we saw a lot of movement in terms of policies being made and other aspects and other places on the global platform, we knew that eventually, because our borders are open, that we will receive our first case in short order. So the hospital itself took time to prepare, identifying a space, identifying protocols to utilize for when the COVID virus made landfall in the Bahamas. Unfortunately for us, that actually took place March 13, 2020 was the first case of COVID-19. The first wave that we saw, there were few deaths, thankfully. The need for high flow oxygen requirement was less. Positives tended to have the described comorbidities with diabetes, hypertension, renal disease, as we were seeing described in the literature. But our second wave was a bit more significant in that we had sicker patients. There were need for higher flow oxygen requirement. There was more COVID pneumonias that were being seen. And of course, there were more deaths. In the first wave, there were a lot of gastrointestinal symptoms, and a lot of persons that came in with shortness of breath were assessed for COVID. A lot of the PCRs in the first wave came back negative, but based on the symptomatology, cough, shortness of breath, we have patients who have heart failure, we have patients with regular pneumonia, we have renal patients with fluid overload. These are some of the patients that were presenting in the initial first wave that required us to assess them properly to determine whether or not they had COVID. The second wave, we still saw a lot of GI symptoms, but there were also persons who presented atypically. You had patients who presented with strokes. You had patients who presented with other symptoms and subsequently developed symptoms that made the managing services suspicious that maybe they had COVID. For those of you who are not familiar with the hospital setting, it was not easy to screen everybody that came into the hospital requiring admission for COVID. However, after seeing the first wave and the second wave, it was determined that it's imperative that we actually have to screen persons before they get admitted into the hospital. When we had the first case diagnosed in March 13th, the patient themselves did not have any recent travel. However, members of the family did travel and travel abroad, and we believe that this might have been in association with the presentation for that particular patient. Regardless, the virus spread quite quickly globally simply because no borders closed. There's a lot of international travel. And if we think about it, this is the reason why we have seen so many persons having COVID in our small population. Persons arrive by airplane, they arrive by boat, and there's travel between the different islands from Nassau as a central point, and there's travel internationally from various different islands. Now, our first peak actually started, our first wave actually started shortly after the first case was diagnosed in March 13th. Our second wave, however, started probably mid to late July, peaked, our greatest peak was seen in October, and then we saw a downtrending on around latter part of November. And so far, despite having the Christmas holidays, the numbers are actually looking a whole lot better than we thought it would have looked. So there are several factors contributing to the COVID spread. One of the biggest factors for us is that there is international travel. That international travel allowed persons to move from areas, and persons were still traveling to areas where there were, especially within the US, where there were rising numbers. Persons can be infectious without having symptoms, without knowing that they have COVID, and they would have intermingled. Earlier in the first wave, there was not a lot of mask usage domestically or internationally. And then when there was a change, persons were still traveling. There were not significant adjustments made with the amount of patients within a closed environment in the plane. So for us, the travel was one of the biggest things that contributed to the COVID spread. Now, when we take into other things into consideration, there is public transportation where there's a lot of persons within a closed environment, like in the bus, and they can contribute to the spread. Also, social conduct of our people. We are sociable people. So despite some of the implementations that would have limited interactions, we still had persons congregating and coming together in groups that were not consistent with one set of persons residing in a home. Let's take, for example, there are persons who would visit a relative, and when they went to the relative, the relative do not necessarily demand that their families wear a mask, sanitize when they come into the home. And some of the cases that we've come in contact with is that you have elderly persons who reside in a home, don't go out. They come back positive because you have younger individuals who reside in the home, or other adults that reside in the home who don't adhere to strict mask wearing, hand sanitizing when they intermingle with their elderly relative. And even within our own household, persons are employed in different places. They may not always adhere strictly to all of the guidelines in terms of wearing a mask, sanitizing, keeping their distance. They congregate to eat without a mask. They will go and touch and will not sanitize. So our social conduct really played a part in also the spread locally. Then we need to talk about non-adherence to the implementation strategies that were laid out in terms of social distancing, wearing a mask in public places, limiting the amount of interactions you had with others, And for within the first wave and within the second wave, we still saw a fair amount of persons that were non-adherent to these strategies that were outlined. Additionally, earlier within the year, during the February and March, we still have persons who have respiratory symptoms that might have been influenza. So there are a lot of individuals who considered their symptoms a common cold and did not see the need to self-isolate, did not see the need to limit their interactions with other individuals. And as a result, later down, when we found out that when they found out that they were positive, they had already been mingling with a whole host of other individuals. Now, when we tried to staunch the spread of COVID, because there are limited resources, our healthcare system would have been overburdened if we had too many cases. There were a lot of things that were actually implemented to see if we can get control. So there was a curfew so that persons would stay within their homes after a certain hour. And this was to decrease a lot of social interactions. If you think about it, persons will interact at work to a particular level. But after work time, there are a lot of persons who congregate and get together and do other things, play cards, play dominoes, congregate, watch a movie. The curfew was to limit those kinds of interactions with people out of your normal environment. And then we also had the weekend lockdown. A lot of people do a lot of social activities on the weekends. So the weekend lockdown was to decrease those kind of weekend interactions to see if we can staunch the flow of increasing number of cases. Closure of non-essential businesses, and I say this tongue in cheek because a lot of businesses do have an essential function, but they were not considered essential at the time. And limiting persons' access and flow in and out with persons getting in contact with others was another way to actually reduce person-to-person contact and potentially the spread of COVID viruses. Now, the healthcare facilities did a lot of things that were different. Within the first wave, and more specifically the second wave, a lot of institutional lockdown on the amount of people coming in. There was also advisement that persons who were otherwise stable but had symptoms would self-isolate at home. They limit visitation to the hospital because the population within the hospital, of course, is already an unwell population. So they limit movements of people into the institution, potentially lowering the risk of these individuals coming into contact with somebody who was COVID positive. The institution also tried as best as possible to identify cases early in persons presenting. So for the Princess Margaret Hospital, it would have been that persons who fit a particular symptomatology profile were screened, and if they were cleared, they would be admitted. There are some persons who presented with no symptoms that got admitted into the hospital, but later developed symptoms. And so things had to be done differently. At Doctors Hospital, they started screening people who needed to have, initially, it was a negative antigen test. And then it was a formal PCR, and those individuals were screened at the onset for when they were admitted. But additionally, they also restricted co-inhabitation in the room, which means that one person was admitted per room. So that actually decreased 2 patients being in a room. So potentially if somebody later came back positive, at least you had to limit the exposure to another person. The clinics tried as best as possible to actually do screening and to limit. They were first line workers in terms of having to triage and sort out routine problems versus individuals who may have been likely to have COVID. And I think that the Ministry of Health actually did a very good job, along with the emergency room, in terms of the things that they've implemented to streamline assessing patients and trying as best as possible to limit persons who potentially would have been COVID positive or had symptoms suggestive of being COVID positive with persons who had non-COVID related illnesses. So they went as far as to also make it possible for persons who are COVID positive and required supplemental oxygen or required some form of medical assistance, whether it was to deal with a comorbidity. They expanded spaces to make it possible for those persons to be cared for. So all of these things were done to see if we can staunch the spread of COVID within the Bahamas. And I think that for the most part, quite a few of them were successful because we did see a downtrending. But there are limitations with some of these things that we implemented. We saw outside of COVID for a person with these measures, some persons had issues because of the restriction. And as when the restrictions lighten up, we started to see that we had numbers starting to climb again. And when the restrictions stopped, so when the borders opened up and when international travels were allowed, shortly after we started to see an increase in the number of COVID cases. So persons flew to Florida and other places. And if you were following the media and you were following the stories and the information that you would see, there were some areas where they did not implement the restrictions that we did in terms of masks, social distancing, etc. There were some places that did not make it mandatory for masks to be worn. And when individuals traveled internationally, I can't say whether or not these individuals actually adhered to the mask wearing, did not congregate, etc. But once the borders were open, we did see an increase in cases shortly thereafter. We also saw a rise in the number of cases when some of the restrictions were limited, and that would be like changes with the curfew, lightening up of the weekend lockdown. We saw a climb in these measures. And you have to consider that things may have happened for a couple different reasons. If you've been restricted for quite a while, the first thing you want to do is to get out. When the beach is open, people wanted to go to the beach. There was not as much social distancing as it should have been. And so there were exposures that were taking place because people congregated together. Even now, we've come across where people were congregating because a lot of persons are sociable. So you've seen cases where persons were congregating in a large group in a small environment, and some of it made it to the media, a lot of it may not have. But these are some of the things that happened when some of the restrictions were pulled back, and we saw a rise in the cases. So when we talk about prevention of future resurgence, this is going to be very, very challenging for several different reasons. However, some of the measures that we can think about doing is screening of persons who are re-entering the country, and it doesn't matter if it's visitors or it's citizens. You think about all of the public health measures that has been talked about sanitizing the hands, mask wearing. Consideration needs to be given for the vaccination program, especially for our at-risk population. It might be advantageous to actually continuing to minimizing people gathering in large numbers. And for many places of work, they should have established guidelines produced to help decrease the spread of respiratory illness within the work environment. And that might be how persons are positioned in terms of desk, how the availability of hand sanitizers, the requirement of wearing a mask within the workplace. These sorts of things need to be considered for future prevention of a resurgence. The challenge is going to be for the Bahamas is that there's a lot of things that we depend on. We don't have limitations, and we do have some limitations with how things are produced, how things need to move in and out of our islands. And so the challenge is going to be how we can continue to be productive and do the things that we need to do while preventing the issues related to interaction and potential spread of the respiratory illness known as COVID. So the borders do have to be opened because that is how income is generated for the most part for a lot of persons within the Bahamas. We know that a lot of persons were adversely affected with all of the lockdown and the limitation of travel. So we've had persons who've been unemployed for a while. And there has to be a healthy balance between prevention of COVID and allowing people to earn a living. And I think that that is a challenge that is more significant than I can talk about in this 25 minutes period. But it is something that healthcare providers, the Ministry of Health, places of business need to consider how we can be productive and still reduce COVID. Thank you.
Thank you very much, Dr. Dames. And I would like to open it up for questions at this point in time. I'd like to encourage persons to type in their questions in the chat box. But Dr. Dames, while I wait to see if there are any questions that are coming in, just wanted to find out from you whether or not we are in a position in the Bahamas to identify any new strains or variants.
Okay. Now, as far as I'm aware of, within the there are mass PCR testing that is taking place, and there are some areas where there's the antigen that is being tested for. And for those of you who don't know, there's a difference between the antigen and PCR testing. So within the first several days of having an infection, the antigen can be detected. Later down, the PCR will be the testing of choice to identify persons because the antigen only lasts for so long. So there might necessarily be newer modalities are being explored for testing, but the combination of having antigen testing available and having the PCR will be useful in us to identifying people who are positive and at risk. Now, in terms of the newer strain, I can't really speak to whether or not we've identified, we have the capabilities or have identified anybody with the newer strain of COVID that seems to be quite virulent.
Okay. I do have another question, and that is if you can just mention the reliability of the different tests that are available to screen for COVID-19, the PCR versus the rapid screening tests and the ones for antibodies.
Well, the antibodies, of all of the testing that is available, the antibody is the most unreliable one. Okay. And so it's not one that is actually suggested that it's an easy test, relatively easy test to do, but it's not the one that provides you with the most accurate information. The PCR, of course, is the standard, but the antigen test is also useful. And using the antigen test, so for example, if somebody was let's say somebody went to a funeral or a wedding where there were a bunch of other individuals and somebody came back as being COVID positive, and it's been within a couple of days, somebody can actually do the antigen test and see if the antigen test is positive to see whether or not that they have been exposed. That's kind of like what the antigen test is utilized for, but the gold standard is still the PCR, which is the best testing modality for COVID at this time.
Okay.
But I will leave the numbers for when the infectious disease specialist. That's either Dr. Bonnaby or Dr. Forbes actually talk.
Okay, and just to mention at this point, the types of vaccines that are available currently that you are aware of, and hopefully the one that you think might be the best one for use in the Bahamas so far, and if you want to mention any limitations to any of them that you think are a little bit daunting.
Okay.
I'll mention one that I find the one that has to be stored at -70 degrees, I think it is, has been, how do we get that one here, and how do we get that one distributed in the Bahamas? So that temperature alone, I think, makes it a little bit awkward for delivery. But maybe you want to just mention briefly the vaccines that are available and which one you think might be the one that you see as being most beneficial to us.
All right. So I did not honestly come prepared to talk about the different types of vaccines that are actually available, and there are supposed to be about 4. And I have my own personal opinions about the vaccine that I prefer not to. All right, vaccine development is one of those things that usually take place over years, and viruses are little sneaky little buggers that like to mutate and alter. So as it is right now, there are, I think that if I remember correctly, there are about 4 vaccines that are in development, and about 3 of them that are approved. One I know is from Pfizer. And the question now that a lot of people will ask about that particular vaccine is whether or not that vaccine will be effective for the new strain that is emerging. I don't know whether or not that is going to be the case, because I don't think that they have tested it for the newer strain of the vaccine. And in terms of which one I think best, I cannot tell you which one is the better vaccine. Um, so I would have to defer to the infectious disease specialist. I know that Dr. Forbes will probably be able to answer that question much, much better than I can.
I saw something this morning, I think it was this morning, that there actually has one in development that's going to be an intranasal spray. So I thought that was interesting. And I think there's another one that's supposed to be 1 dose instead of 2 doses of vaccines in order to give you the immunity. So you're right. I think that there's a lot more that will evolve with time. And I agree that maybe I will pose this question to the ID specialist in the next session.
I think that would be the best thing to do in terms of asking about.
I do have a question from Dr. Beneby, and it reads, I understand the need for multiple factors to be in place, but what is the single most effective factor in control of the spread of the virus?
To be honest with you, Dr. Beneby, the short answer for that is really for most people to practice good hand hygiene, and in this current time, always wearing a mask.
Totally agree with you, Dr. Dames.
Because anything else is after the fact, but that probably would be the best thing for self-protection that will work.
And I see a comment here from Soraya Halkitis. I presume that is probably Tracy. That says storage for the Pfizer and the Moderna vaccines require liquid nitrogen for -80 degrees Celsius. So, I think that is going to be very challenging for us to get that particular vaccine, but we'll see what happens.
I think that they're reading through some of the information that was available. They said that they were trying to create areas of cold storages for the vaccine, but there still are going to be technical difficulties in maintaining that degree of Celsius, even in transportation from one location to the next.
And then I see one from Dr. Linwood Brown that says, will persons who already have had the COVID-19 infection be required to get the vaccine?
Mhm. Well, that's an interesting question for two reasons. Once you've had COVID, the thinking is that you um, should not be able to get COVID again, that you should have built up an immunity. There have been a couple cases that were described when it seemed as if somebody got reinfected again. So as it is right now, I don't think that persons who were known to be COVID-19 positive require getting a vaccine.
Do you know, Dr. Dames, of any cases here in the Bahamas where any persons have been infected twice with
No,
COVID-19?
not infected twice with COVID-19. Now, it's possible for persons to shed inactive virus, so they can be tested, and recurrent testing may show that they still have virus present, but the virus may not be active. They probably would have cleared it. So, like if somebody 14 days, 21 days afterwards got retested, what might be seen is inactive virus that is still shedding and not active disease or not being reinfected. But as far as I know, there's nobody who has been reinfected.
And Dr. Brown asked again, is the reinfection rate greater than the vaccine failure rate? And I think that probably I'll answer that one for you. That left to be seen. I'm sure none of us will know that for any time
No,
soon. But
no.
Dr. Frankson asked, and this would be the last question, if the contagiousness of the virulence, do you know if it has increased with the newly mutated virus? And that would be our last question for the
Okay.
night, Dr. Dames.
For as I was looking, as I was reading, it seemed to be that this one is a bit more virulent. Okay, but the funny thing about looking at, well, not with the new strain that is available, but there are actually some conditions like mild asthma that seem to have had better outcome, and you would think things like asthma persons would have had a worse outcome in terms of COVID, but it actually seems to be a little protective. I found that a curiosity when I was actually looking through the things, and they can't say with absolute certainty why that is, but there was some explanation put forth. But we won't know about reinfection rate or anything with the vaccine failure until much later. They do have to be vaccinated, and we will have to see what happens afterwards. But there isn't sufficient vaccination going on to be able to answer that.
Okay, thank you very much, Dr. Dames. We'd like to thank Dr. Dames for her presentation. And we'll move on now to our next presenter. Thank you, Dr. Dames. Our
You're
next
welcome.
presenter is Dr. Shrikant, who is a consultant plastic surgeon at PMH since August of 1999. He did his medical training in India and received his degree in 1990. He went on to complete residencies in general surgery and plastic surgery with additional training in hand and microvascular surgery, and also obtained his fellowship from the Royal College of Surgeons in Edinburgh. For the initial 9 years, he covered trauma and general surgery along with his plastic surgery duties at PMH. Subsequently, plastic surgery became an independent unit along with the burns unit and wound care. He provides plastic and reconstructive services at Doctors Hospital. Dr. Shrikant loves interaction with younger physicians and has a passion for teaching. He has been a part of the University of the West Indies School of Medicine, Clinical Medicine and Research since 2001 and is a lecturer for both the MBBS program and the DM program. And he has been a tutor for the DM Family Medicine and Accident and Emergency program since 2014. So he's very much all involved in every aspect of everything that needs anything to do with surgery and teaching. He has been an examiner for the MBS and the DM programs for many, many years since we had our program started in 1997, and I can't think of a time when he wasn't here. He's a member of many professional bodies, including the Indian Association of Plastic Surgeons, American Society of Plastic Surgery, International Association of Aesthetic Plastic Surgeons, and the Royal College of Surgeons of Edinburgh, and the Medical Association of the Bahamas, for which he has presented several times over the many years. I'd like you to welcome Dr. Shrikant, as he is fondly known, as he talks about the collateral damage of the pandemic. They, meaning all of those things, did not go away. So Dr. Shrikant, I'll invite you to take over, please.
Good evening, everybody. Can hear me?
Yes, we can.
Okay. Thank you very much, Dr. Sinqui, for the introduction. And thank you to the UWR Research Unit for inviting me to speak on this topic. My other role for which they chose me to speak this topic is being the director of the operating rooms at the Princess Margaret Hospital. So what do we mean by they did not go away? We are talking about all the other clinical conditions that are still prevalent in our society, in our country, and that still require treatment and management. I'm specifically going to concentrate on the surgical side of the collateral damage of the pandemic. I thank Dr. Dames for setting up the program for me and letting us know that the pandemic caused a lot of changes the way we dealt with in the country. When this pandemic started, one of the first recommendations of WHO was to minimize non-urgent facility-based medical treatments while dealing with the pandemic. Services became increasingly disrupted as a country moved from sporadic cases to community transmissions of the coronavirus. Services were also disrupted with the imposition of widespread lockdown curfew, like what happened in the Bahamas. The first case that came into our country, the minute it was identified, we went into an immediate lockdown. By the first few weeks, there were papers started coming out, and a complete reporting system to the WHO reported by June 1st said that health services had been partially or completely disrupted in many, many countries. Health staff working in the area of non-communicable diseases were partially or fully reassigned to support COVID-19. Partial or complete disruption of services for treatments for NCDs like hypertension was almost 93%. Diabetes and related complications was close to 50%. Cancer treatment was 42%, and cardiovascular emergencies were 31%. Elective surgeries were uniformly canceled. Rehabilitation services were disrupted uniformly, and screening programs were suspended. By another few weeks, 2/3 of the country started reporting that they included non-communicable disease services in their national COVID-19 preparedness and response plans. But there was a clear disparity. 72% of the high-income countries managed to put plans to manage their NCDs, whereas 42% of the low-income countries only included them. They tried to include services that would represent urgent care, cardiovascular disease, cancer treatments, diabetes, and chronic respiratory failure. Many services like dental, rehabilitation, psychological, and screening were initially not thought about until a little later in the pandemic. Especially the psychological aspects of the pandemic started to take a toll on the various segments of the population. The most important reasons the WHO reported were for disruption of health services were the immediate cancellation of planned treatments. Like we called all our patients and said, you're not going to get your surgery or your treatment done. There was lack of public transport. Imagine you're in a lockdown and you depend on public transport and you cannot get to the hospital. There was lack of staff or facility due to reassignment. There were shortages of medications. There were diagnostic shortages because resources had to be moved to attend to COVID. And there was shortage of PPE material. We all know about that. But in developing countries, that initial statement was true to most countries, but developing countries has a special problem. Because of the lockdowns, it disrupted our services. But what COVID-19 showed us was that the chronic lack of investment in our health infrastructure, which was poor to begin with inadequate ICU beds, resulted in a devastating effect. There was challenges in human resources. There was gaps in health services. We know exactly how, when Dr. Dames was mentioning what processes they could implement at doctor's hospital, we could not implement those at the Princess Margaret. And access was kind of difficult as to how patients were accessing them. And one of the most important rate limiting steps was the limited access to testing. And specifically on our country, again reiterating, lockdown had the most major impact. We had to create capacity to treat COVID overnight. We didn't really have. We had shortage of the 4 M's that we talk about: materials, machinery, money, and manpower. We redistributed our scarce resources. For example, South Beach Center became a COVID designated center. We had to get in Doctors Hospital West. We had to design new policies and procedures that fit our country, our needs. And in the operating theater, we had to design a new protocols. As I again mentioned, lack of widespread testing was a main impediment. And right from the get-go, we wanted the patients that are coming into the facility in Princess Margaret Hospital needed to be tested. We haven't reached for about 9 months until recently. This resulted in incidental COVID exposure to staff and patients, resulting with down the line complications. What I'm looking at is specifically the numbers of procedures done at Princess Margaret Hospital. This excludes the private operating theater at Princess Margaret Hospital. We have Assist Analytics that has been implemented for the last three years. It's still a learning curve with us, and we are still, the data that is being input is not completely correct or appropriate, and we're still learning. But it's still a great tool that helped me bring out a lot of numbers. But as I go along, I will let you know some of the deficiencies that I found. We compared the 2019 versus the 2020 data. I had to collect the iTheatre data separately because they are not in the SIS system. Remember, there were no elective admissions or no elective surgery. We started doing only emergency Tier 5, which is life-threatening cases, and then Tier 4, which were the urgent cases. Preference was given to obstetric, vascular, orthopedic trauma, and oncology. Cases were grouped based on the services in my presentation, and cases were not separated based on the time of the day or acuity. Like, was this a life-threatening operation, or was it done in the certain time of the day, or was it done in the time of the night? I just collected them over a period of time. Just looking at the total numbers in 2020, we had about 4,522 operations, whereas in 2019, that was 4,805. Even though this number is not completely accurate, as I point out in the bottom 3 months, April, May, and June, the Public Hospital Authority system got hacked, and we lost a lot of data. So if you look at those cases, you would notice that we are on an average trend around anywhere between 400 to 500 cases, whereas we are bottomed down here at 250, 118, and 244. So the numbers probably are much higher in the year 2019, but still compared to that, the total number of procedures were less. It might look as if though we did do a lot of operations, but let's go a little deeper into some of the other numbers. If you look at obstetric service, the number of operations obstetric service did in 2019 was 912. By 2020, it increased by about 10%. But there is a specific reason for that. The minute the hospital went into a lockdown, the private operating theater was also in a lockdown mode, and most of the cases in the next 3 months moved down to the public side. So that could explain. But relatively, obstetric service continued to provide the services that these patients needed. But if you delve down, I did not look in the data about maternal mortality or infant mortality or the morbidity, because a lot of patients did not get access to their obstetric care, but presented at the end. But just looking at the raw numbers, the numbers matched up. Orthopedic service, similarly, was doing as many cases as they did in 2019. Again, because they were given access to that. You might think with lockdown, the cases of operation should have gone down, but not really. Remember, at lockdown, people started exercising, doing things that they probably never did. And there were a lot of fractures, there were a lot of patients coming in, and their service continued to provide the service straight throughout. So the numbers never changed. Vascular service, similarly, again, this could be an indirect result of the fact that these patients did not get their adequate maintenance, preventative care. So more and more patients presented with complications. And as a result, the number of surgeries required in 2020 increased by almost 30%. So my vascular colleagues were constantly on the go straight throughout. But I want you to recognize that there was a dip in, as you go through most of these numbers. So if you look in the previous numbers, both obstetric, orthopedic, as well as vascular, April is the month that there was a dramatic dip. And by the time May came around, the numbers started going up. So we started figuring out how to deal with COVID and its attendant complications, and then we continued to provide services. Oncological service had a 200% jump, because that's all we were concentrating on. We were trying to get these cancer patients into surgery. Earlier times, probably the numbers were not readily available access to theater, but now with the already increased access to theater, the number of oncological surgeries increased. So all of this looks good. Gynae oncology, the numbers remain the same. Cardiothoracic surgery, again, the numbers remain the same. What does this tell us? This tells us that at best, Princess Margaret Hospital is always been an acute care center. We've been dealing crisis cases at the brink of emergency mode. We never truly do a lot of elective surgery. There are few specialties, starting with urology, which notice that it is down by 100%. There were like 50% of the cases from 2019 to 2020. Spine and neurosurgery, spine was the same, but neurosurgery cases decreased. Get into plastics. Plastics does a lot of elective cases, so you can see there's a 50% reduction. ENT, there was a 25% reduction. Pediatric surgery, a 25% reduction. Endoscopy reduced by 40%. So these are the elective procedures that are done, but these decreased. Where did these patients go? They're still there out in the community. They're still waiting for the hospital to accommodate their needs. And this is what we are seeing. But what is the most tremendous difference that we found was in the general surgery area. We had, again, 33% decrease in the number of cases done by the general surgeons. Most of the deficit is your elective cases, like your hernias, your lumps, a lot of cases that need attention but did not. I did not really, again, bring out the morbidity, the cases, but anecdotally we know we had more hernias presenting with obstructions and strangulations during the last 9 months, and this led to have invasive surgeries and longer stay for these patients. Gynecology, even though the numbers have dropped, and they say they have done 514. Majority were very minor procedures, the CPT coding. We really did not do any major gynecological procedures. None of them, we didn't really do a lot of hysterectomies. The majority of the major procedures happened in January, February, March, and recently at the end of November and December, we started doing a little bit more cases. But in the intervening cases, we really did a lot of small minor cases that needed to be tackled. One of the greatest tragedies I consider is the ophthalmology. Remember, ophthalmology does a lot of elective work, a lot of cataract and glaucoma. They're in their normal course of work itself, they have a lot of backup. People wait about 4 months to get an eye clinic appointment, and their surgery date can range from anywhere from 6 months to 9 months to a year. Their numbers dramatically dropped, 824 in 2019 versus 167 in 2020. So this, I'm pretty sure we will be seeing a lot of complications coming out in the next few months. So what are the lessons that we learned, that I have taken from this? One of the first things is that managing our COVID fear. Initially, it was irrational. We had lots of people who were unwilling to come to work. There was a fear. And then as more and more data came about, we started to make more rational decision making. We learned on the job as new data appeared, not only in our country, worldwide. As I pointed out, many of the services at PMH are acute care services. Like, for example, orthopedics, vascular, and oncology. We really don't do a lot of elective work in a lot of services. If you look at the elective cases, almost all branches of the surgical specialties have been affected, some much more than others. Ophthalmology, general surgery, gynecology, ENT, plastic surgery, we all been tremendously impacted in our inability to do elective cases. I don't remember doing an elective breast reconstruction for the last 9 months, and we have about 110 breast cancers that are operated in this country every year, roughly. So it's a lot of unmet need. COVID-19 exposed the severe shortcomings of our healthcare system. We know Princess Margaret Hospital is an old woman, as I just heard recently from one of the hospital administrators. It's 60 years old. It needs a lot of tender loving care. A lot of system joints are not working, and it needs a lot of replacements. And that put into our system with COVID has really created a unique situation. We have had repeated manpower shortages at the height of the second wave. Our department in surgery was down to about 8 functioning junior doctors. And when these residents came back, we had to allocate them to the COVID teams. But in spite of all of this, there is a silver lining. I mean, I'll always like to look at some bright things that we still continue to do so that we can take cues from it. Our acute care surgery never ceased. Our anesthesia colleagues, our nursing staff, our surgical staff never stopped working. So we continue to deal as we were dealt with. What is the future? This is what I believe. COVID is here to stay for the near future. Whether we have an effective vaccine, by the time we get a worldwide population vaccinated that allows herd immunity, COVID is going to go around like a merry-go-round from one country to the other. We've seen that happen with Europe. So we might be low right now, but we will be probably having a surge sometime in the near future. So we have to develop viable strategies to deal with COVID-19, but at the same time deal with all the other healthcare conditions that affect our population. We cannot keep them on the back burner forever. We need to be able to deal with them. One of the important factors is we need to test all patients before they come into surgery. And thankfully, it is happening in almost all cases, except the emergencies, including the obstetric emergencies. We still are not able to do those cases. And as recently as today, we had another patient who had an emergency operation and ended up turning out to be positive after the case was done. And now the patient was in a ward, so that ward goes into closure. Now that's a different matter of discussion with IPC teams as to how we manage and mitigate those things. One of the other things that we continue to ask right when the COVID pandemic started was that we should test all patients admitting into PMH, and it's a reality now. All patients coming in through the accident emergency are being tested, but there are still a lot of challenges. We all know how cramped our accident emergency is. So all of these patients who are getting their tests done, but they are still right next to each other, and that would be a positive case is still gonna expose other patients that are right next to each other. So there are still things that need to be ironed out as to how do we isolate patients that come in and are tested. So we need to develop protocols for that. From the surgical theater side, we probably need to target specific conditions. We might have to target a specific hernia list, which is a daycare surgery. We might have to create a dedicated ward for elective admissions. No matter what happens, that a ward at PMH is dedicated for male admissions, a ward for female admissions. Knowing what bed shortages we have, that is not going to be a reality, but that is what we need to work towards, so that we continue to bring in patients based on timelines where we can say this patient only needs an elective admission for 48 hours for surgical admission, and they come in and then we turn over that particular patient. So we need to think outside the box. We need to adapt policies and strategies that work for us in our environment. We can look at other third world countries or other countries and see what is best working for them. And going forward, we should do that. And with that, I would like to conclude my presentation. I would like to thank staff nurse Anastasia McKinsey, who was my partner in going through the CIS data. I also thank Dr. Anna Green, who helped me get the data from the ophthalmology operating room. Thank you very much.
Okay, thank you very much. I'd like to thank Dr. Shrikant for the information that he shared with us. Very important information, and I think that all of us have felt the impact of the lockdown in the surgical area and not seeing our elective cases being done. And I do have a question for Dr. Shrikant, and I understand your thoughts with regards to having a dedicated area to house the elective patients. And I understand your thoughts probably to try and create an elective surgical list. But can you give us any more ideas on how you plan to catch up the backlog of cases? Because I think this is going to be the biggest challenge for you, and whether or not there is a log that has been kept so that we know which cases we have to schedule and how you're going to embark on doing this. I think you already alluded to the fact of certain complication that has occurred, mainly because of delay in the surgical procedures done electively, mainly for the hernias. And, I think that there's probably more fallout that is going to occur from other things that should have been corrected, should have been done, and has not been done. So can you give us a idea of the bigger plan on how you're going to do the catch up on these cases?
That's a great question, Dr. Sinqui. Unfortunately, I don't think there's an institutional plan anyway. We don't really have that kind of logbook or data to go back at patients. Individual services, and I can only speak to about my service in the plastic surgery, as we have a logbook of our patients that we know that need surgeries or that have been coming into our clinics. The other thing that I failed to mention, that we actually started doing in-person clinics, the surgical side especially has been doing in-person clinics. So and gynae is also doing, gynecology is also doing the in-person clinics. When we are getting these patients, we are all creating our wait list and we are trying to get to them. But I think it requires more from the institutional support, that we need to do public service announcements, and we probably have to get back into the community to tell people to come back. Because on my other things that I do, I go into the community and there is a major fear of coming into the hospital. And therefore that fear needs to be mitigated among the population also. So no, we don't really have, I don't know how we're going to catch up to what we already have there. It's just a matter of when they start coming in, we need to start dealing with them.
Oh.
And also, just to mention, when the like in the last 1 month or so, when the lockdowns have kind of eased effectively, our trauma went back up again. This year started off with a bang. We had multiple gunshot victims, multiple gunshots. So that aspect of the society that we always had is now going to come back. And remember, I said PMH has always been an acute care setting hospital, and that's going to be a biggest challenge. I don't know how we're going to establish, how we're going to do that, and without increasing capacity, both in the OR, but there are so many rate limiting steps.
Well, I know you mentioned trying to find an area to house the elective cases. And, I'm going to invite thoughts on using the tent that was constructed for COVID cases as one that you might consider as an area for short-term stay.
Actually, we discussed it this morning in our OR committee meeting, and it was immediately shut down because remember, the COVID is still around. So the administrative side, they're still worried about having but there are so many other things going on right now at PMH. The A&E redevelopment project is going on. The wards, some of the wards are being redeveloped. So a lot of things are happening. I said our PMH is a 60-year-old woman with a lot of joints being replaced. Which one are you going to replace? What are you going to do? These are all the questions that need to be sorted out.
I'd like to invite any other persons who have questions to type it into the chat. But I do have one other comment, and that, I think that COVID-19 has allowed us the opportunity to look at new ways to deliver care. And that, we do need to strengthen a lot of our areas, and a lot of it can be done without money. For example, I think that you might want to look at the scheduling of patients in the OR so that we have improved efficiency, so that when we have a taskmaster who is saying that, okay, your case is scheduled to start at 9, it needs to be started at 9, not at 9:15, not at 9:30, so that we can actually plan for the maximum use of that time. And it's going to be especially important when you have the opportunity to start doing the elective cases. So, I don't envy your job. I think that it is going to be a task, and I think that you're up to the challenge. And I hope and pray that we do see the return of elective surgery soon, because there are some that are more urgent than others to do.
So just on that last point, elective surgery has been started for the last 2 weeks. We are doing daycare case surgeries more and more. We have started to allow gynecology to address the women's health needs a lot more, but we don't really have elective admissions, and we can't bring in a patient to electively get admitted for surgery, and that's still a challenge. But we are working. Hopefully, that's the way going forward. Yes, Dr. Benabi. I see Dr. Benabi says thinking out of the box.
Two comments. One from Dr. Clark that says necessity is still the motivation for creativity at times, and Dr. Benabi says thinking out of the box must be the context of the present resources, especially this being a developing country. So with that, we are right on time. If there are no other questions, I give 1 more second for anybody to type in their question. And that second is up. So thank you very much, Dr. Srikanth, for this enlightening presentation. And we'll move on to our third speaker. And our third speaker is no other than Dr. Glenn Benabi. And he is somebody that is well known to all of us. He's been around a long time, and many of us have encountered him in several capacities. And, now that he is retired as our outgoing Chief Medical Officer of the Commonwealth of the Bahamas from 2014 to 2018, we definitely know him only too well. He's also a graduate of the University of the West Indies, and he did his postgrad studies in anesthesia at the University of Sheffield in England. He also has an advanced diploma in public administration and public management. He was involved in medical management for more than 25 years, as we are well aware. He was our medical advisor of the Public Hospital Authority, appointed in 1999. and he was actively involved in clinical anesthesia practice and healthcare research, and in fact wrote a book, for those of you who don't know, on the topic of anesthesia in the Bahamas. He's a lecturer, author, and international guest speaker in anesthesia, a pioneer in the development of anesthesia in the Bahamas, Caribbean speaker at the Anesthesia World Congress in Montreal, Canada in 2000, and received citation by the U.S. Embassy for Health Service contribution in the Caribbean in 2005, and the recipient of the WHO PAHO Centennial Health Hero Award in 2002. He's a member of many organizations, and he's a founding director of Physician Alliance Limited, a founding faculty member and acting director of UWI, a founding director of Allied Health School in 2010. He is the board chairman of Coastline Community Nursing Home since 2006. He's an active member of NGOs and supporter of many community services. And he is also a physician leader and university lecturer in professional ethics. He was recognized with the Health Hero International Hall of Fame Jackson Memorial Hospital induction in February of 2020 in the Black History Month. And he has been a guest speaker of PFN Global Leadership Forum on Healthcare and Financial Global Pandemic Crisis. He's married and father of one son. So it gives me great pleasure to announce my mentor, who helped to shape a lot of things that happen in medicine in this country. And his talk is there another threat more deadly than COVID? How should we prepare? So Dr. Blenby, please take over.
Thank you very much, Dr. Sinki, for that kind introduction. And I thank the persons who are responsible for this UWI forum, which is most appropriate at this time. Allow me to say that because of where I sit, I think I have the liberty to make some more challenging proposals that some may consider out of the box. But the question for me tonight is there another threat more deadly than COVID-19? And the immediate answer is yes. And what is more important is how should we prepare? Here we have this first slide, which is just a diagrammatic view of the COVID virus itself, showing the coronavirus with the spike proteins. So there we're looking at this diagrammatic, beautiful pictorial view of a colorful coronavirus. Of course, you know, the coronavirus itself is nanomolecule, and so this is overly exaggerated to give the benefit of the discussion that will follow. Next slide. Here we have a slide that forms the basis for this discussion. This shows the spread of the coronavirus globally throughout the world. And what I want you to notice, which is very particular note to me, and I think should be to all of us, is how the virus crowds itself into the first world. The first world, you can't see the map in the first world, but in the third world, in developing country, it is just speckled. And that is something that we need to pay attention to, because this virus, notwithstanding the deadly nature of the virus, has been more deadly in the developed world than it is in the developing world. And I think there are lessons to be learned in that process. Next slide. During this talk, we will talk about this under 7 headings. I will first give a background overview of the history of pandemic viruses and pandemic diseases. Then I will talk about the definition of the crisis, what makes it a crisis. And then I will go and talk about the areas of priority as healthcare workers and healthcare providers that we should be focusing on. And then I will look at what tools are available to us. Shukan was beginning to talk about in this talk. We heard a few points from Dr. Dames. What tools are available to us for preparedness, and how do we use those tools to prepare? And then I thought to put in a slide to bring home the reality of the COVID-19 crisis and talk a bit about the staggering reality in the world because of the crisis. And then to look at major invisible challenges, which we don't take note of, but they are very important. and I will bring those to the fore. The concluding slide will show what are the expected goals, what do we expect to achieve, and what are the outcomes that we are looking to get to because of having this COVID-19 virus experience. Here we look at this. We don't appreciate how much knowledge we have over the years, from 1346 to 1835 to bubonic plague, which was a bacterial disease rather than a viral disease, but bacterial disease. And what is critical is how is it transferred? How is it transported? This was a virus that got from the flea bite that was on rats. And this is very important because of the aerosol nature of the coronavirus, it is far more dangerous than having a bite of a vector of a mosquito or something similar. So the virus is very, very dangerous because of its aerosol nature. What is more hypothetical is if we consider of the possibility that if it was possible for the virus or some other organism to enter the body through the skin and not have to go through the nasal airways and passages, that will be a real problem for us. And that is something that we ought to sit on pins and needles as we think about it. And then we look at the cholera disease, 1600, with Dr. John Snow, who made himself famous simply by changing the head of a public faucet in London. And it goes to show how you could disrupt the spread of disease by studying its epidemiology and looking at the cause of the disease, which we are trying to do now with this coronavirus, which started in Wuhan, China. And then we had the pandemic of the flu pandemic, 1889, and the one which is far more popular than that is the Spanish flu, 1918, which most of you would have heard about, particularly now, because most of the practices we use now are an extrapolation of the Spanish flu 1918, 1920 disease. And that is what has been very helpful when we reflect on that. And then the Asian flu in 1957, 1958, that caused a scare. And then we had AIDS epidemic. When AIDS epidemic, we thought it was a death sentence for the world. And I'm so pleased as we speak today, we are in a point where AIDS is now a chronic condition, and it's possible to live with AIDS by taking medication like you do with diabetes. It just goes to show what improvements healthcare technology and man has made and continue to make. And we take these things for granted. SARS disease in 2003, another coronavirus, MERS disease in 2012, coronavirus, similar challenges, but we were able to trap or mitigate these diseases. The Ebola virus, because of the quick action of the World Health Organization in particular, this disease was limited mainly to the African continent and not spread in the pandemic set throughout the world. Zika virus just occurred in 2015, we know that. And every year, we have an influenza virus because we have to get the flu shot in order to be compliant with the WHO and the FDA requirement, CDC, and accordingly. But what I'm trying to get over to you is the coronavirus, though novel, it is not unique. And we may be looking at an endemic virus. Somebody mentioned that earlier. This may be endemic. We may never get rid of it, and it becomes a cycle in the course of public health. Next slide, please. Here we have the definition. What makes this a global crisis? Decisions. This is a decisive, difficult moment of danger. If you don't operate and get control of the virus, there's human mortality and morbidity, significant mortality and morbidity. And there's a correction there that morbidity is spelled incorrectly, but we go on. It disrupts financial commerce and supplies disruption. This, Shrikant made a little mention of it. People do not appreciate how the supplies of the world is disrupted by the coronavirus. At every place, at ports, at airports, at seaports, at transportation, trucks, at borders, everything is affected by it. The culture changes occur acutely. We used to expect culture changes to take years to occur. Culture changes occur in matters of days. They have to change the culture of the operation of a society, of a community to cope with the coronavirus. The existence of human race is threatened. there's the belief that if we don't get on top of this virus and get on top of it soon, we're going to decrease the population of the world. And that is what is causing a lot of trouble in the minds of many people. There's a global shift in global independence. Before, everybody wants their own sovereignty. They want to be by themselves. But what we realize now that we are all interdependent. And if we don't cooperate with across borders and across countries, places like Europe and elsewhere, if you don't, you find that you have problems in your country because of not being in contact with another country. Next slide. This threat is the threat to the whole human race. The potential of every single person being infected is on the board. Millions of deaths. And you see from the slides I was shown earlier, it's about 2 million deaths right now as we speak. And it's increasing every day. It's going up by 1,000 or more a day, 4,000, as I will show on a slide later on. But there are vulnerable groups. There are vulnerable groups that are normally vulnerable, and there are vulnerable groups that are not normally vulnerable, but become vulnerable because of circumstances. Elderlies and children, because of their immune systems, are normally vulnerable. But we forget, pregnant women are now in the group of vulnerable patients. Comorbid conditions, people who have cancers, diabetes, hypertension, immune, multiple sclerosis are all vulnerable things, all vulnerable patients that we must look at, assess, and keep in our focus. This is an ongoing problem. It is not something that you could stop and sit down and wait, and we'll do something tomorrow. It is a continual research that's necessary in both biotechnical research as well as artificial intelligence, which is hype in trying to answer the questions that human minds find difficult to deal with. And big pharma comes to play in the studies to deal with the production of drugs. That's a point I want to touch, because it is the belief of some that big pharma is influencing this so significantly that certain drugs like chloroquine and Invectin are not used because big pharma don't want them to be used. They prefer to have the vaccine solution. But this is something that have led to serious discussions in many healthcare quarters. The pathology of disease, what actually happens? The disease affects more organs more than others. For instance, the respiratory system is far affected. Yes, there's some small effect on all of the system, the gastrointestinal system, the kidneys, but the respiratory system is the main system that suffers the cytokine storm, and you have the mucus plugs in the airways, and it leads to lack of oxygen and hypoxia, and that is a major factor in the pathology of this disease. Patients SO2 oxygen saturations fall rapidly below a normal of 95, and they find themselves, and this is a measuring factor they actually use to determine whether the patient should be hospitalized or not. And if so, then how should that be done? And there's modification of how you use the oxygen. Ventilating the patient as a first step in some patients may not be the right thing to do. Although in our normal patients, we look at just hypoxia and ventilate. In these patients, we have to look at other things, putting them prone, using high oxygen flows, rather than just following the normal steps. So this shows how this condition modifies daily the need to alter the way you treat patients. The epidemiology of the disease, how is it distributed? We are seeing that coming more and more as a challenge. We thought it was something that only elderly people in old folks' home had high risk, and yes, they are. But for the first time now, we're seeing it in young people in some areas and in younger people, and we are afraid what it may happen in school children. And so that is causing a lot of destabilization in the community at large. Effects, it's a very deadly disease. Yes, it has quite a number of people who recover, but it can cause death in the short and long term. And I put short and long term because we have seen the number of deaths that are going up significantly, but we don't know what is going to happen long term further down the road. The disease has not been around long enough for us to know what is the outcome and the prognosis of this disease. All we could say is that it's deadly in some cases, more deadly in other cases, but it is disruptive in all cases. Developed world is more affected than the developing world. And this is something we need to note. And I want to stress this because we in the developing world is of the mindset that we always have to look to the developed world for answers. And in this particular disease scenario, the developing world has better answers than the developed world. Africa has shown better demonstration of developments of tests. They developed ventilators at far cheaper costs than the developed world has done, and they have made better use of their resources than the developed world. And it also shows that basic hygiene practices, public health hygiene practices, has been better implemented if you look at WHO statistics in the developing world than in the developed world. Interesting to note, because more money does not mean better results, but it is something for us to think about when you're thinking about thinking out of the box. The social determinants of health have been magnified. Lack of education, lack of potable water, lack of proper schooling, all have been magnified. And so Afro-American communities and people who are poor have magnified disease disparities. The system has blown out of proportion when it comes to looking at what are the effects of these diseases in the system. More deaths occur among this group. And this is something that it shows us our weaknesses. It brings to bear our shortfalls. And Shrikant mentioned this, but this is very important. Previous normal operation of healthcare services must be maintained in parallel. We don't consider that because with other things, we say, well, we're going to focus on this disease, focus on that disease. But as we focus on the new disease, which is a world threat, global pandemic, at the same time, in the margins, out of our vision, the old elective conditions, the cancers are going on, the prognosis is getting worse, and we have to make changes in our therapy to decide whether we treat patients who have cancer and develop coronavirus infection as well. And if so, what you treat them with? Do you modify the treatment? Do you use the same monoclonal antibody treatment? Or is it necessary to combine monoclonal antibody treatment with some other form of treatment? These are very, very interesting times for us. Next slide. The tools available to us to prepare. It was the great general MacArthur who said, in the time of peace, prepare for war. Well, we're in the midst of a healthcare war now, public health war. And it's during this period of peace, so to speak, that we have to make the necessary changes to deal with the future. Somebody said earlier, necessity is the mother of invention, but perhaps we ought to look at it as opportunity creates opportunity of a crisis, gives us the opportunity to do positive things. And the things that we must focus on now is the management, not just the materials, but the management of the materials. We see the problems we had with the PPEs because we don't manage them properly. They come and they're not in the right places. They're not being distributed properly. Manpower is a big challenge for us. And why that's such a big challenge? Because the persons who are involved with the frontline healthcare are getting sick. And we're challenged. Doctors are dying. Nurses are dying. And it takes you many years to train one of these very professional persons. Money is inadequate. And we know that as a matter of fact. It was inadequate before the crisis began, and it's inadequate now. The leadership needs creativity, innovation, and initiative. You have to be prepared to do things that was not done before and to re-engineer. Somebody mentioned the importance of, I think it was Cynthia who mentioned the importance of the tent construction at PNMH, which I think, in my opinion, was not adequate use of our resources. We have resources in country that will serve us far better. We have healthcare facilities in country that will serve us far better than building tents. Samaritan Place, that is not the situation. And we can modify our treatment far better if we use all of our healthcare resources than what we are doing now by fighting against ourselves only in the public facility and limited use of the private facilities. The universal hygiene standards holds good, and the role of World Health Organization in this regard is well founded. And so we should not limit ourselves. We should continue to be a part of the World Health Organization daily briefings, and the CDC and the FDA and the NIH. We should be in all. And the challenge we have faced is we are not having enough discussions among the leadership in local physicians to get consensus with what's going on. Right now in the country, we don't know who's using ivermectin, who's using chloroquine, and who's using doxycycline. We have no consensus. There's nothing going on. One or two of us want to do it, and we do it at our own peril because somebody comes afterward and say there's no consensus. Regulations are key, and it needs to happen quickly. Policy and politicians tend to get into the challenge of it. You know what as well as I do, President Trump left WHO. Serious challenge to globalization interdependence. And with him, he took large sums of donation. And this affects the whole world. Doesn't only affect the United States, affects the whole world. Healthcare, as we know it today, has to change. The systems has to change. The role of telehealth and telemedicine becomes a priority. And there is no doubt about it, if we fail to utilize these services, we will fall far short of the mark. We had presented the first telemedicine health regulation in this country in 2002 and 2003. They have been on the shelf somewhere gathering dust. I heard one of our leaders spoke 2 days ago or so, we're looking at doing telehealth and telemedicine going into the future. But those words are good, but we need to put in place a mechanism for implementation. The difference between success and failure is not knowledge, it's implementation. Public education is key. Wellness and lifestyle are very important because we're talking only about global pandemic, but in order to deal with the global pandemic, you have to deal with wellness. And we need to continue to deal with lifestyle changes, which we have been discussing all along. We have to get in the habit of excellence in terms of health and set up benchmarking everywhere. I congratulate our National Health Insurance system, which is now being improved and updated with the data that will allow us to do follow-up for patients and to determine how well they're being treated in country on a more global scale. That is to be commended. Testing and surveillance is key. Testing. We don't have enough testing. They don't have enough testing globally, anywhere in the world. So we're not short on that, but we are far shorter as a developing country than we ought to be. And in the absence of testing, you cannot do proper surveillance and you cannot do proper epidemiology, follow-up and research. You don't know where you're looking. It's looking for something in the dark. So you need to do testing appropriately. And as you know, testing is increasing everywhere now. Travel testing is increasing. Testing is increasing where you can go back to school, not go to school. Who you test, very important. Strengthening of our human immune systems. This is the broad, something that is not new. We know this. We know that we have to pay particular attention to our nutrition, to zinc, vitamin D, and the likes. And we must exercise 30 minutes a day, at least, to get the basic exercise in. We must drink enough water. These are very simple things we do it. We have sunshine here, and we should go out, and we shouldn't have a problem with vitamin D in this country. But people don't go outside. People stay in, and we have vitamin D deficiency. Vitamin D is a key component in normal immune systems. And then we must do these things in moderation. For instance, we must stop drinking large amounts of consumption of alcohol. Don't smoke. We know these things, and we have to do those things which will help us to maintain wellness and keep us going right. Also, aeration, ventilation. When you think about the COVID crisis, air conditioning makes it worse. Cold situations make it worse. It's better to have natural ventilation, to go outside and move around. Rest is critical. We take rest for granted, but you need a minimum of 8 hours rest a day, and not just lying down. You need proper rest so you can have delta wave functions and you can have healing and repair of organs. And the last thing, but perhaps not the least, is trust. You must have some faith and focus in a spiritual force or some force, positive thinking to get you better. It has been proven. Research has shown that these things, if we take them for granted, we are making a mistake. I have mentioned here the therapy. Why I mention the therapy here is that nobody talks significantly about the viral load of coronavirus. We know viral load makes a total difference to the expression of a disease. And so if you treat the infection before you have a significant viral load, it's likely that the disease is not going to be as profound. And that is the place for chloroquine, ivermectin, and dexamethasone. Of course, dexamethasone has an additional effect when it comes to patients who are ventilated because of the autoimmune suppression of the immune system. At the end of the day, we are looking to a virus. This is the silver vaccine. I say virus, vaccine. This is the silver bullet, but oh, ain't that a difficult silver bullet? This new vaccine is full of challenges because we just don't have enough experience with it. This mRNA vaccine is but a big problem. The Pfizer model, a big problem.
Dr. Benny B, we have 2 more minutes.
It's a big problem. You put me in a handcuff, but I will get there. Long-term treatment, the development of herd immunity is where we want to go. Because it's taking the world so long to get herd immunity, most likely the pandemic is going to become a worldwide endemic situation, just like how the flu virus is at the moment. Next slide. These are just, I'll go through this very quickly. These are just staggering results that we have to look at, and this is what makes it so challenging. The worldwide deaths are more than 1.9 million. The deaths in the United States is almost approaching the population of the Bahamas. So if you can figure that everybody in the Bahamas died, it'll match what's happening in the United States. There's a death every 30 seconds in the United States. More than 4,000 every day since the 8th of January. They estimated that they will have 20 million vaccines by the end of December. They're far from that. They only have 20% vaccines. That's another problem in itself because it's not getting the vaccine alone. The logistics of how you get the vaccine to where they need to be and the resources needed to give the vaccine is causing major hurdles. And that is causing them to have to set in place systems to deal with that. The shortage of human resources. Every area, they're trying to employ more human resources, places, more nurses in particular. And the new effect just come out, and those who are in medical schools will know about this. The 20% increase in all physicians intake in medical schools has happened this year, and it is called the Fauci effect. These are invisible things. I have 2 more slides. I hope Cinque will give me the opportunity to deal with this. These are the major invisible effects that we don't have control over. Mutations. The virus is mutating regularly. It mutates in the UK, it mutates in South Africa, it's mutating, and because of the mutation, the vaccine may or may not work. And Scott Gottlieb, who's the CDC board member, has made particular note about how dangerous that is in the context of the efficiency, of the effectiveness, of the efficaciousness of the vaccine. We don't know what it is. Understand that. Everybody's talking about vaccine. We're not sure it's going to be able to deal with the spike protein. The major disruption of healthcare supplies in every aspect, I talk about that. The health chain is being disrupted totally. And not only that, people are being biased. At one point, the United States decided not to allow PPEs to go to certain places. I think the Bahamas was one for a short period. And so we're in trouble. They don't allow certain drugs to be tested certain places. You're in trouble. So no equitable testing and treatment of the poor. It's a problem. If you don't have the World Organization in place, it becomes a problem. Major role of political leadership. And Dr. Trump, and Mr. Trump, I should say, demonstrate that more than anywhere else. And of course, in our local situation, we have regular briefings from our competent authorities. Fake news. There are active groups who are making it difficult for scientific evidence to take root because they have YouTube and they're setting out information of how dangerous vaccines are. And pediatricians in particular having problems with keeping up with the normal vaccines because they're being told that these vaccines are going to program us and 5G and they're going to be able to do things that is unbelievable. Public trust is eroded. Major funding requirements are required, the normal funding, unplanned funding. So in the future, just like how you have a fund for hurricanes in the region, for Dorian and other countries, the Caribbean has set up a particular funds. the Caribbean region is going to have to set up a particular fund to deal with public health crises and pandemic, in my opinion.
So this is the final.
Final slide, yes. Let
Yes.
me come home now. Let me come home, Sinki. I'll come home to you. Elimination of the causative undesirable agent, the coronavirus, is unlikely. If you notice these things, I classify them as unlikely or likely to be accomplished as part of a preparation. And that is what I use as a measure of the balance in where I came to my conclusion on this topic. It's undesirable, unlikely to occur to get rid of the virus completely. Long-term mitigation is likely because we have demonstrated in developed and underdeveloped developing countries, the better effect has been in those countries. So money is not a problem. If you put your policies in place and do them correctly, it's likely that you could have mitigation. Timely restoration of your public healthcare system is unlikely. It costs too much money. You need more time to do it. In the short term, you're going to find that those things that you can't talk about that needs to be done is going to be difficult to accomplish. We have big challenge with the adverse reactions and complications. We know now Michael Gregory, a doctor from Mount Sinai Hospital, has just died 2 weeks after getting the virus. It's turned the whole apple cart upside down. He developed thrombocytopenia. We don't know whether it's idiosyncratic. We don't know why. But the fact is that is gone like wildfire. It's gone viral throughout the world. A doctor died because of post getting the virus. The new norm being predictable is unlikely. So that's unlikely. We can't predict what's going to happen. It's changing too fast, and it's too many things changing at the same time. Lessons learned, wonderful lessons learned, and we are learning from them. I wouldn't enumerate them, but we learned that we could do far more than we anticipate we can do if we apply ourselves to it. Standard preparedness strategy is working just like how you have for hurricanes. We need to have a standard preparedness strategy for global pandemic. Investment in prevention, manpower, technical, financial resources must happen as a part of the annual budget. Some 5 to 10% must be set aside, financial budget to deal with public health issues, not just to catch up, but to have in place the materials that need to be done. We're running out of everything, even in normal circumstances. Global mammoth task. This is an important point. Public-private sectors partnership, which is likely, and we take it for granted, but public-private partnerships must be reinforced because the virus does not discriminate. It affects everybody, and we must use all the resources. So there's room for optimism. I want to end here. There's room for optimism because more likely points that I present for preparedness are achievable points. There's only 5 that are achievable out of the total 4 are not. And so you can see there is a balance, but the balance tips in the direction of optimism. I look forward to the optimists taking a half full glass to a point where we'll be satisfied with it becoming full.
Thank you very much, Dr. Beneby. And I know that you did a lot in your years, giving us a solid foundation from which we are to build. I'm sorry I don't have any time for questions, but I ask that people still type in the questions that we can redirect them to Dr. Beneby at a later point. Thank you very much, Dr. Beneby. Our last speaker is Dr. Robin Roberts, somebody who probably needs no introduction. He has had a most colorful career with a resume that is most impressive. Dr. Roberts, like 2 of our 3 prior speakers, is also a graduate of the University of the West Indies. He has been a recipient of numerous scholastic awards, and he attained his fellowship from the Royal College of Physicians and Surgeons in Canada, having completed his postgrad training in neurology there, and then he attained his fellowship in clinical renal transplantation at Dalhousie in Halifax. He returned to the Bahamas in 1997, where he was appointed the first consultant urologist at PMH. And since then had introduced a lot of urological care to the entire Bahamian population for over 30 years. In 1996, he performed the first kidney transplant in the Bahamas. His administrative and managerial skills permeate every fiber of the healthcare services in the Bahamas. And I can only describe Dr. Roberts as a nationalist, a visionary, and a pioneer. He has held several key positions as he built the foundation for us to springboard off. He has been the chairman of the Department of Surgery, was the first director of CME activities in PMH. He's a senior lecturer and first Bahamian director of the University of the West Indies of Clinical Medicine and Research, the Bahamas. He's the director and president of Physician Alliance organization and a founding member of the PMH Hospital Foundation. He served as the president of the MAB, president of the Commonwealth of the Bahamas Research Academy, president of the Bahamas Family Planning Association, president of the Caribbean Neurological Association, vice president of Caribbean Association of Nephrologists and Neurologists, co-vice chair of the National Task Force of Gender-Based Violence, and you name it, Dr. Roberts has been on it. It's just too numerous to count. And I'm not sure if many of you know, but he was probably one of the great driving force for the creation of the National Insurance Board and all of those guidelines and rules and regulation as we know it from way back when. He is currently the director of the National Health Insurance Program, and he is our director of the University of the West Indies School of Medicine and Research since 2007. He is very instrumental in bringing the medical school to the Bahamas. So even though he wasn't our first director, he, along with Dr. Beneby, was very instrumental in bringing that to fruition here. And since the undergrad program helped in the development of the postgrad program, it is also important to see that he was recognized at the national level, and he was awarded as an officer of the Order of the British Empire. And even though it's the Order of the British Empire, I think it is just more heartwarming to see that he was recognized nationally and internationally. So I welcome Dr. Roberts to speak on the changing face of medical education post-COVID. Dr. Roberts, please take over.
Good evening, everyone. Thank you, Dr. Sinqui, for those kind words. This evening, my presentation focuses on the impact of the COVID-19 pandemic on medical education. Our generation of physicians is living in our first pandemic. And as Dr. Beneby told you, nearly 100 million documented cases and 2 million deaths worldwide. The impact on the delivery of health and medical services is being devastating. Its impact on medical education is being brutal and disruptive. But the imperative and the mandate to ensure that both our medical undergraduate and postgraduate students achieve and maintain the desired skills, knowledge, and competencies of the profession has been quick, adaptive, and unwavering. Adherence to social distance has led to the adoption and implementation of readily available technologies in medical education, including video conferencing softwares and social media platforms. In so doing, we have transformed every facet of medical education literally overnight. So first, I want to look through the lens of time to travel at the speed of this COVID-19 transformation in the education of a doctor and a specialist. I want to view the impact of the pandemic on the current landscape of medical education and the disruptive impact of COVID-19 pandemic. And finally, the paradigm shift to the virtual and online teaching and learning environment. So let's look at the evolution of medical education and its transformation and the rate in which it occurs. Well, we all know the father of medicine, Hippocrates, and he actually popularized at that time that disease was due to the four humus, looking at the black bile, the yellow bile, phlegm, and blood. And he aligned these to the elements of nature, earth, air, water, and fire, and that even determined our personality types. But this theory of medical education lasted for almost 2,000 years. it was not until the Renaissance in 1500 that medical science was born. And then we had the great anatomists like Vesalius or William Harvey in physiology looking at blood circulation. We had people like Leonardo da Vinci and so on. And then it took another 100 years before we had the Flexen Report in the United States. And that basically came about because of all the quackery from medicine that was occurring in the United States at this time, unlike where you had in Europe, that university education was mandatory in order to become a doctor. That did not happen in the United States. You could actually, anyone and anybody could have set up a medical school. Most of them were for profit. And so when Flexner was given this task by the American Medical Association Committee, his report, he visited every one of the 155 medical schools in the US at that time. And at the end of the day, he proposed a single model of medical education that we have today, university-based science and research foundation, the 4-year curriculum, and in Britain and Europe, we still have the 5- and 6-year curriculum. He established admission requirements, and medical schools appointed full-time clinical professors. So within 10, 20 years, he had closed down most of the 155 medical schools because they just didn't meet the standards. And there were only 66 by 1935. And then it took another 100 years before we saw another transformation in Europe, and that was led by the Tomorrow's Doctor in the United Kingdom. And the GMC at that time, made it very clear that we needed a new doctor for today. The high cost of medical care because of advances in technology and pharmaceuticals. We had an aging population. We had to learn how to manage limited resources. There was how to handle medical education. There was so much new knowledge. How much should a young doctor know? How big a curriculum should be? How do we integrate this early exposure in medical students and rather than separating this preclinical and postclinical? And how do we focus the curriculum to be student-centered? And then he looked at the learning environment. The more, we were having more critical patients. We looked at moving from hospital to outpatient care to population-based medicine. And then on the other side, you had the patients. We had patients that were better informed. You had the internet. They wanted to participate in their care. You had issues of informed consent. And they were more prone to sue their doctor. And so putting forward a new doctor, and in addition, there was not only a Tomorrow's Doctor, the new doctor for the millennium, and then you had a new doctor that came about in terms of the career planning, and then you also had postgraduate medicine with regards to how do we modernize medicine, modernize medical careers, and aspiring to excellence. So you had about 5 or 6 fundamental papers. At the end of the day, it took about 20 years in Britain, in which at the end of the day, it was established that once you started medical school, in order to become an independent medical practitioner, you had to be a certified specialist. That changed things overnight. And then, just at the cusp of establishing postgraduate, undergraduate and postgraduate medical education reform, in comes COVID. And within just 9 months, looking forward from 4,000 to 300 to 100 years to 20 years, within 9 months, okay, COVID has made more changes in our curriculum as we see in our own Faculty of Medicine, Medical Science at the University of the West Indies. For the past 20 years, we've had the CAMHP, our certifying body that was trying to harmonize our medical curriculum. We practically did that within the first 4 months of COVID. Okay, we started to exchange our faculty. We started to exchange in the preclinical program, started to exchange lectures. We even had, for the first time after fighting, we could now harmonize the pathology program across the board and deliver it online, which we thought we could never do. We just had a recent exam in which we had a single virtual platform for all the postgraduate students, reducing costs and the need for travel. And in just that one shout, it's very clear, we'll never go back to our traditional way. in which we conducted our examinations and assessments. So it is like within 9 months, we have skipped 2 decades of bureaucracy in the university. So the evolution of medical education, the transformation of medical education during the COVID era has been phenomenal. But back to the basics. The basics are that medical student is an apprenticeship. It's all about on-the-job training. We know very early in medicine, this is how you learn medicine. Tell me and I'll forget. Show me, I may remember. Involve me and I'll understand. So we learn the old-fashioned way, one student at a time. Practice-based learning is the backbone of the education of physicians. Hospitals, clinics, and community services are where future doctors learn, forge professional identities, and develop an orientation to patient-focused care that shape their practice. And then, feeling very comfortable that that's where we should be, on the 15th of March, 2020, the acting Minister of Health at that time had a press release telling us that we are our first case of COVID infection in the Bahamas. It meant that on the 16th of March, the next day, school was closed. No medical student was allowed in the hospital. No direct patient interaction. What a disruption. No in-person teaching. We know very clearly, William Osler said, medicine is learned by the bedside and not in the classroom. We have been out of the hospital for 9 months. For 9 months, our students have had no clinical experience. This is fundamental in their education, training, and progression. So what are our challenges we face? We have to provide a new learning and teaching environment. We have to go to remote online learning. We have to change our assessments. In some cases, some universities were even looking at deferring students until at least the pandemic had settled. So we had to be flexible, we had to be responsive, and we had to be creative. But then, you know, looking at that and what to do with our students is what I call a triple-edged sword. Because in one instance, we were directed for the safety of the students, so we moved them away from the patient areas. And then we also realized too that they could have been potential vectors, carrying home to their patients and their families. But the realities are, and as Dr. Benby would have said in his talk, that treating diseases is an inherent risk in medicine. I mean, all through history, you can look at how physicians were on the front line. We are on the front line now. We talked about how many of our physician colleagues have died, even locally, and our nurses. And so how to manage that inherent risk is a part of our learning experience. How can we deny them that? And then, of course, there's the whole issue of them not being available, as mentioned already, because we're trying to preserve our limited PPEs. So let us look at the preclinical students. We're very fortunate in our students in the first, second, and third year. This is not an issue for us in the Bahamas, but it's an issue that we see in our other 3 campuses where they have the full 5-year program, where we have didactic lectures, a lot of them are. So that was easy to switch online. We had pre-recorded lectures and video conferences. That was quite easy to do because we didn't have, and in place of having labs and library, and in fact, today a library is almost becoming obsolete. You can get anything you want online. But then we missed something in preclinical. We talked about the transformation of the curriculum from being divided in preclinical and clinical, where most medical schools now are talking about the integrated curriculum, where we expose our preclinical students very early to our patients and start learning history and physical examination and communication skills. But then, you know, COVID, as I mentioned earlier, harmonized the 3 campuses. We began to share really share for the first time. We even talk about our students who can get they can get a transfer in their first 3 years and have and do their studies on another campus. That never happened before, and so that's good. Probably one of the best things that our medical students like is the fact that, boy, we don't have to wake up for those morning lectures anymore. I mean, there's a big fight for the past 20 years since I've been in university. There was a whole issue. Should we have these lectures? Can we get rid of them? But now the students appreciate that they can have their lectures online. They can be viewed at their convenience. And more importantly, they can be viewed at different times. And you can even, at some university, look at it as, you know, it's a very dangerous thing in our limited resources right now. If you got to do all your preclinical online, why you need 3 preclinical schools? Why don't you put all of that in one? That's, you know, the financial folks would say, that's an amazing merger. We can save a lot of funds that way in reducing our faculty and resources and so forth. So these were things you would never think of prior to the COVID-19 epidemic. When we look at our clinical clerkships in our 4th and 5th year, again, I have to look at Sir William Osler when he said, "He who studies medicine without books sails on uncharted sea, but he who studies medicine without patience does not go to sea at all." So it is critical for them to have this patient interaction. But then, in the meantime, in the interim, we tried to get as close as we could. Schools open up with the bigger access to an online repository of patient interviews, recordings, and cases. We did a lot of online teaching. In fact, I was shocked to see that some students, literally 6+ hours a day, they would have been online switching between lectures. But they need patient contact. And teleeducation is no substitute for patient contact. And this whole transition happens so acutely. Now, when we look at our 5th year students, well, these were the ones that were just about to graduate. So we felt that we had to make some, again, major changes. We had to acknowledge and saw the importance of our formative evaluations, of our end of clerkship examinations. And we had to say, listen, we think that these students, mind you, they have fallen short by about 2 months or so, but we feel that we have evaluated them, we've looked at their program, that they have had enough to be functional to move in as interns. We need, in some places, they look forward to the internship program in order to meet their manpower needs, their physician manpower needs. We had medical counselors, we had certifying bodies that took, that they looked at waiving those end of stakes, those high stakes exams, so that the students could get into the hospital, they could be doctors into practice. Things that we never would have thought about doing in terms of the transformation process that we've had. And so we look at, again, another impact of COVID in our medical students. And our postgraduate students, that's quite interesting, because what happened is that we can look at 3 stages in our medical education, what happened in our postgraduate students. There are those that were in a position where it was business as usual, where there was no significant disruption of education activities. There was another stage where there was an increased demand, and some residents and fellows shifted to patient care, and their educational activities were suspended. And then you have the pandemic emergency, where the majority of the students or our residents shifted to patient care, and most educational activities were suspended. And that essentially is what happened in our residence programs. So much to the extent that at the time of the postgraduate exam in anesthesia, they tried to make the case that they felt that an emergency medicine, but particularly anesthesia, they felt that they had been working so hard and doing so much service work that they had proven their worth, that they should have been given their certification and to move on to practice medicine. So We had deployment of our physicians in areas outside of the educational mainstream. We had rotations that were disrupted. They were assigned to unfamiliar areas. We had a whole new teaching environment now with very high acuity patients and working in ICUs 24/7. There's a whole new aspect of donning and doffing of PPEs. And then up comes exposure to telemedicine. No direct patient contact, but it's as close as you could get. And so even in our postgraduate students, we had to adapt to virtual learning. What are the cores? Well, it might be good to be in the virtual learning, but we lost our traditional bedside teaching round from social distances. Deployment was out of whack. Service commitment, predominantly, we were providing service at the peak of the COVID epidemic. We were not really into effective teaching and learning. So our learning decreased, our ability in terms of our knowledge and progression decreased. We are higher output in terms of burnouts and moral injury. What is the long-term effect of that? So I'd be very interested to see what Dr. Barrett will be talking about that on the next talk. There was decreased patient experience because we had decreased admissions, decreased elective admissions, decreasing procedures, and this was worse in the surgical specialties. So what kind of skills do we expect our postgraduate students to have because of this pandemic? Should we give them another year? We lost our didactic conferences, and then vacations were shortened or postponed or canceled altogether. And half of the treaties, and more than half in some studies in North America, as well as across in Europe, show that more than half of the students, they express serious concern about being overworked and burnt out. And even at our consultant level, our teachers, okay, conferences were canceled for them. I never saw the year would pass and I never set foot at an international meeting. Virtual meetings became the order of the day. I think it's very clear that for many of our specialties, that probably would be the only way they would conduct their meetings as time go on. We had growing clinical and administrative demands, as well as we had our faculty members that they had their issues of dealing with their being quarantined or the fears of themselves getting sick. And so we're not surprised that a fair amount of our lecturers were unable to provide the educational output that they should. And I think our full-time faculty are, I think, true to say that they were burnt out. So when we had finished giving all that we could, as we moved our undergraduate program to everything online that we could, devoid of our being inpatient, teaching, that no one disagreed with the fact that maybe we can lighten up in November and keep our fingers crossed that come January, we'll be back in the hospital. Unfortunately, we have been. And so we made a major switch to virtual learning. We adopted implement already available technologies. We had rapid changes overnight. Classroom lectures were gone, virtual lectures, and it's amazing. As I mentioned earlier, we're having these lectures virtually. Attendance has been almost 100%. The students loved it. It was convenient, etc. But there's some serious barriers to teaching in a virtual format. There's time. There's time. God is very demanding. You got to have the technological know-how. You got to have access to an online platform and an appropriate bandwidth. You got to have access to reliable equipment and the internet. You got to find the right platform, and there are quite a lot of them, but I think everyone has turned into Zoom. I wish I had bought some stocks in that to see all the multi-million users that came on. And these are the things you want in your desired platform. Well, we should have HIPAA compliance on certain things because you're talking about patients' confidential information or something close like it. We got chat that's available for interaction. We got desktop share. We got a whiteboard. We have breakout sessions. And we have other strategies and tips to optimize our virtual learning education. We got a buddy system. So we can have co-teachers. We can employ a team and teaching online, like how we are doing now today. And I would be remiss not to say thank you, Darren, for bringing this whole thing to fruition. So as we interact in our virtual field, we also want to make sure that we integrate on our online teaching. And there's so many techniques where we can enhance making better communications, employing virtuals, asking questions, getting the students to talk, getting them to move. And so as we switch to virtual learning, we really want to optimize what all we can get out of it. And we can put so many activities in the virtual education, in our virtual education program, from journal club to case and pathology conferences, to a review of practice questions for board exams, telehealth precepting, standardized patient encounter, regular communication with clinical questions and relevant articles, research discussions or meetings. And so these education activities, the platforms are available, and practically all of those that are readily available. We have Twitter and WhatsApp and Slack and video conferencing software. So this has been fantastic. But the online switch has been demanding, it's time consuming. We got to learn how to navigate it. We still are quite separated, but we're still, you know, what it does, it actually brings work home. It's like now, you know, we're home and we actually actively in the classroom. So we got to have a whole new life balance, and it can be very stressful. So on the one hand, then we have a negative impact, psychological health with increased rates of stress, anxiety, depression, and other negative feelings. But on the brighter side, you know, this virtual communication platform keeps us better connected as colleagues and friends and family, as well as social and our work-related communities. But we have to ask ourselves, are we losing our clinical skills? Here is the thread of online learning. How do we interact with our patients? How do we become clinicians? Not to look, but to see, not to listen, but to hear, not to touch, but to feel, not to sniff, but to smell, to taste, but to savor the aroma. You know, some will tell you, why you want to examine an abdomen? When an ultrasound can tell you what's going on. Why do you want to listen to a heart? When you can have your nice new stethoscopes linked in digitally, they can tell you much better than what you can listen. But you know, if anything breaks down, you never miss the water till the well run dry. These are serious concerns we have to entertain with regards to advancing our profession. So we got to live with COVID. How long? We don't know. It's going to be a long time. So we have a whole new world of social distances, of teaching and learning. It's going to be small groups, and we're going to create these stable social bubbles. We have to reduce the frequency of our rotations and our movements and the number of individuals or students within the rotation or within a firm. We're talking about virtual ward rounds. We're talking about resuming the clinical experience, even for our consultant level. But on the bright side, we're going to improve our public health competencies. Then, when we thought we were out of the clinical world, we've got another added feature that has really come to life in the COVID area. While it was slowly coming along, at least for us now, for the first time, we are talking about acquiring a simulation unit. So, what's simulation? Well, basically, it's about we are imitating our human processes and we are interacting with models. It's a new learning and assessment tool in medical education, and its use is being explosive. And basically, we're talking about body types. They can be structural in terms of task trainers, learning how little models, how to feel, how to do prostate exams and breast exams. We can have standardized patient actors. We can have a combination of both. We can have computer-based simulations. And then we can have functional attributes, the reliable ones. And we move and talking about low fidelity simulators, medium simulators, high fidelity simulators. I mean, these are all mannequins. Whether they're static, whether they have mechanical movement, or whether they're actually in virtual reality. And to watch one of these in action, it is amazing because it literally is virtual reality. How to run a code to tell you whether you're doing the right things, whether you're giving the right drugs, and how you can have the patient, and the patient might die on you. And so we're looking at this as our static mannequin. This is one of our middle fidelity mannequins, whereby you're learning interactive with regards to learning laparoscopic procedures. And here you're looking at the real thing here, whereby when you monitor this patient and it's just like you're in ICU, with all the bells and the whistles with regards to managing these acute care patients. And then on top of it, not only just for clinical, but also for our preclinical. So we've gone from the cadaver room into our virtual table. And it's as if you were inside your cadaver. So simulation has actually brought visual learning to life. This is a whole new area of medicine. It is now a new specialty in medicine. You can now go and do a fellowship in simulation training. They have multi-million, simulation centers costing over $100 million and more. And so we are very much in the embryonic period here in the Bahamas, I think in the Caribbean with regards to that, but this is the future of medicine. And here is the beauty of it. That whole dictum that we grew up with, be no more see one, do one, teach one. Simulation allows us to practice and to get better by repetition until you are almost perfect in what you're doing. And so we move up from being a novice to an advanced beginner to competent to proficient to become a master. Even though we kill the patients 100 times in order to do that, the patient is very much alive. And there's increasing evidence to go to show the impact of simulation when you move from the mannequin to the live patient. And so simulation, we've been able to define our outcomes and our educational goals. We've been able to utilize multiple learning strategies, a controlled environment, a wide range of complexities, student-directed learning, repetitive practice, provision of feedback, integration with traditional curriculum, and the evidence increasingly showing the validity of simulation as we transfer to what is actually happening in the real world. Simulation has allowed us to fill those gaps in medical education that we have. So our contact time that we have with our patients. So even though we have less time with patients, we can improve our efficiency, we can reduce the cost, and we can reduce the cost of the patient, and we can reduce the time the patient has to stay with us in terms of improving our skills. Safer for the patient, reduce medical errors. One of the advantages of simulation is that the modern informed patient makes it very clear that they do not want to feel that they are guinea pigs being stuck 10 times by the medical students in order to perfect his skills at setting up a trip. We have sicker patients now. And because things might be infrequent, we can have simulation whereby the conditions that we rarely see, we can imitate them every day so that we can become masters at it. And finally, one of the other things that we have found works so well in our virtual learning and periods of stimulation, we can show in our new transformed medical education, and COVID has shown the spotlight, as Dr. Beneby said, on inequities and how we can have we can better deal with these issues of access and resources and healthcare and how they can improve our patient outcomes. But we have to ask then, what will our next generation of doctors become when their main core of learning is virtually online or in simulators, but not touching those patients as they should? Well, finally, we have telemedicine, which now will become an integral part of our training, particularly at the postgraduate level. And so it's going to be second stage in the offices, senior citizens at home who can't come out, on the wards, particularly when we're looking at doing our virtual rounds that we're talking about, or when we're looking at we can't get inside the inside the intensive units, or here it is. We can actually interact with our patients in these critical care areas. And we can call directly from home to find out what's happening with our kids. We can directly interact with our patients online. So telemedicine has become an integral part of our teaching as well. And we've been trying this for some time. I dug up this old slide. It showed that we were looking at this from 2011 when we had our first telemedicine program. Again, it shows you, going back to one of my original slides, that these are the barriers in terms of acquiring the equipment, in terms of maintaining the equipment, in terms of having the right bandwidth. So the time has come for us to relive this again, and we have to do better. And so our social media and technology has transformed medicine and medical education. And so we need to redesign medical education to meet the needs of the digital world. Pandemic has put this transformation on overdrive. There is no turning back. I would be remiss for my last slide not to mention that in the heat of this, our National Health Insurance Program is leading the way. In our primary care transformation initiative, we have some 100,000 enrollees to date. We have new electronic health records in which almost all of our enrollees are on the platform. So we will be very soon in a position whereby we can, with a click of the button, we can see what the health conditions are in our population and how we can design and tailor the programs, the intervention to better the health of our population. And telemedicine is actively in use. So I look forward one day, very soon, because I had this slide for saying this is where we should be in 2030. No, we are already here now, today, that I can be in the control room at the Princess Margaret Hospital or the Rand Hospital, and I could be conducting healthcare. I can have a medical student with me. I can have them on the Family Islands, and we can be interacting, and they can be actively learning at the same time in this environment. I say the future is here. It's here today. Thank you.
Unfortunately, we do not have any time for any other comments or questions because we're running over time already. But I'd like to thank the entire panel for this very, very engaging collection of thoughts and ideas and presentations. And I do agree with you that COVID has fast forwarded what probably would have taken a lot more years to come about in medical education. I'd like to remind everybody to attend next week's symposium, and we'll have another one in 2 weeks' time.